Urinary tract infections are among the most frequent bacterial infections, varying from benign to severe, life-threatening conditions. Antimicrobial resistance has increased, which further complicates treatment. The 2024 European Association of Urology Guideline provide evidence-based recommendations for diagnosing, treating, and preventing urinary tract infections and male accessory gland infections, focusing on infection control and antimicrobial stewardship. The guideline summary emphasizes the importance of urinary tract infection classification, which ranges from benign to life-threatening, and these aid to help stratify patients to tailor diagnosis and treatment effectively. Regarding asymptomatic bacteriuria in adults, which is defined by a bacterial growth of 10,000 colony-forming units per ml in urine without symptoms, the guidelines recommend to not screen or treat asymptomatic bacteriuria in women without risk factors, patients with well-regulated diabetes, postmenopausal women, and renal transplant patients, and patients with recurrent UTIs. On the other hand, it is important to screen and treat asymptomatic bacteriuria before urological procedures breaching the mucosa and in pregnant women with standard short-course treatment or single-dose fosfomycin, with cystoscopy and imaging not required if medical history is unremarkable. Regarding uncomplicated cystitis, diagnosis is based on history and symptoms, with urine culture recommended only in specific cases such as symptoms that do not resolve or recur within 4 weeks after the completion of treatment, or women who present with atypical symptoms, with suggested antimicrobial regimens being either fosfomycin or nitrofurantoin in women and trimethoprim sulfamethoxazole in men. Regarding recurrent, uncomplicated UTIs, the guidelines strongly emphasize on the use of non-antimicrobial measures such as increasing fluid intake, vaginal estrogen replacement, immunoactive prophylaxis, probiotics, cranberry products, D-mannose, and hyaluronic acid installations. Regarding uncomplicated pyelonephritis, which is defined in non-pregnant premenopausal women without relevant urological abnormalities, initial workup should include urinalysis and a urine culture, with initial ultrasound recommended. With regards to the suggested empirical oral therapy, fluoroquinolones and cephalosporins are the initial antimicrobial agents of choice and are recommended for both oral and IV empiric treatment. In particular in men, a 2-week treatment duration with a fluoroquinolone is recommended, as prostatic involvement is common. Next, with regards to catheter-associated UTI, these are the leading cause of secondary healthcare-associated bacteremia, and the mortality associated with this condition is approximately 10%. Indeed, it is estimated that the incidence of bacteriuria associated with indwelling catheterization is 3 to 8% per day. In these cases, a combination antibiotic treatment is generally recommended. Regarding urosepsis, it is important to assess the severity using a SOFA or quick SOFA score, and to assess urine cultures, 2 blood cultures, and when applicable, fluid drainage, and to start high-dose broad-spectrum antimicrobials within the first hour. With regards to bacterial prostatitis, acute bacterial prostatitis should be treated with fluoroquinolones or trimethoprim sulfamethoxazole, and if they present with urinary retention, suprapubic catheterization can reduce the risk of chronic bacterial prostatitis in the long term. Finally, if there is an associated prostatic abscess, drainage is recommended if more than 1 centimeter. On the other hand, chronic bacterial prostatitis is associated with poorly localized pain, which persists at least 3 months. The recommended treatment is fluoroquinolones for 4 to 6 weeks. Finally, with regards to periprocedural antibiotic prophylaxis, in urodynamics, cystoscopy, and extracorporeal shockwave lithotripsy, no prophylaxis is recommended, with prophylaxis recommended only in high-risk patients if undergoing transurethral resection of the bladder.